All right. Good afternoon, everyone. Thank you so much for joining us for today's webinar. My name is Jessica Halsey with the Addiction Policy Forum. APF is part of the HEAL Connection Center, which works to share important findings and resources from HEAL-funded research. Really excited to be able to share some of the great work that's been done through the Healing Community Study today and our presenters. Our topic is how to build opioid data dashboards for community decision making best practices from the Healing Community Study, and a few housekeeping items just before we get started. You can add questions for our panelists into the Q&A section at the bottom, and we'll reserve the last 20 minutes of our webinar to try to get through as many as we can. A recording of today's webinar, along with the slides, will be shared with all participants and registrants after, so stay tuned and look in your email inbox for those. We will also send along a certificate of participation and a digital badge, which can be turned in for CEU credits for those that are interested there. So I also wanted to give a big thank you to the team at Addiction Policy Forum that works on the Heal Connections project and support for the Healing Community Study, including Braden Kelly, Julia Rosenberg, Grace McGann, and others. So thank you so much for all your hard work in organizing today. So I'm very excited to introduce our presenters. The bios would take me a half an hour to go through, so please click through on your follow-up email if you want more information about our sort of subject matter experts and our presenters today. But I'm very excited that Dr. Jennifer Villani is joining us, the Associate Director of the Healing Community Study at the National Institute on Drug Abuse, NIDA. We also have Dr. Elwin Wu, Professor of Social Work at Columbia University, Peter Balvance, who's an Associate Director of Informatics at the Boston Medical Center, Dr. Daniel Harris, Associate Professor at the University of Kentucky College of Pharmacy, Dr. Nalif Farid, Associate Professor at the Ohio State University College of Medicine, and Dr. Timothy Horta, Professor of Family Medicine at the Ohio State University College of Medicine as well. So thank you for taking the time to be with us for today's webinar. And so thank you so much to our speakers for being here. And I will hand this off to Dr. Villani.
Great, thank you. All right, we'll go to the next slide. Perfect. So good afternoon, everyone. I feel like before we get to dashboards, I need to sort of set up the talks for today. So I want to walk you through a very brief history. And you'll see in this slide that arrow is pointing down at 2017. And you can see this comes right after a pretty steep rise in the opioid overdose death rate. This was also when the opioid crisis was officially deemed a public health emergency in the US. And as a result, shortly after that, the National Institutes of Health pulled together leading experts in substance use research and developed a research agenda to accelerate scientific solutions to stem the opioid crisis. We knew we had evidence-based tools in our toolbox to treat people with opioid use disorder and prevent overdose deaths, but a piecemeal approach wasn't going to be sufficient. We needed a large coordinating effort. We needed all hands on deck. And that's really how the Healing Community Study came about. So go to the next slide. And it was definitely needed. The Healing Community Study was launched in January 2020, right when the opioid overdose deaths were increasing precipitously. So go to the next slide. The goal of the study was to reduce opioid overdose deaths by 40% because we needed a target and needed to be bold. We enrolled 67 communities that were experiencing high opioid overdose death rates at baseline from 4 states. These communities covered over 10 million people. We designed a multi-site, parallel arm, cluster randomized waitlist controlled trial where half of the communities received the intervention starting in January 2020, while the other half served as the control. And then the waitlist control received the intervention. And the intervention we called the Communities That Heal intervention, and it was a framework for mobilizing these whole communities to form a coalition, use data, and develop an action plan to increase the treatment for opioid use disorder and ultimately save lives. Next slide. So briefly, here's a quick map of the 67 communities that were enrolled in the study. Those in darker purple and orange were in wave 1 and received the intervention first. And those in the lighter purple and orange were in wave 2. They were a waitlist control, and they received the intervention second. So next slide. So what was that intervention? Well, the Communities That Heal intervention had 3 components. First, we focused on community engagement, where we helped communities build coalitions, review the local data about the opioid crisis, develop action plans, implement them, and monitor the results. Then we also had a menu of strategies that we called the opioid overdose continuum of care approach, and that was coupled with technical assistance guides. The Addiction Policy Forum has actually done a webinar on this ORCA, as we like to call it, and I highly recommend you watch that. The menu listed evidence-based practices for overdose education and naloxone distribution. It had practices for medications, for getting out medications for opioid use disorder and for safer prescribing. So there were sort of 3 menus, and those were our 3 target areas. Finally, we also created a public health communication campaign where we tried to drive demand for naloxone and medications for opioid use disorder, and also try to reduce stigma in the community. But the key to all of this work was the data used to drive the decision-making at the community level. So go to the next slide. We needed a quick, accessible way to transfer data and information relevant to stemming the opioid overdose epidemic in each of these communities. So the 4 research sites, in collaboration with the community coalitions, conducted a landscape analysis using publicly available administrative data and online searches to identify existing resources and organizations in communities that could help with the opioid crisis. This information was compiled into a community profile, which summarized sort of at baseline the resources that we had, the gaps in the community where we could actually, do some improvement, and opportunities where we might increase adoption of some of our evidence-based practices. In addition, the 4 research sites also co-created dynamic web-based platforms to visualize data related to the study outcomes. Each intervention community had a data dashboard designed for them to support decision-making and monitor community-specific metrics. And soon you'll see examples of those dashboards from each of the research sites. Next slide. So, but if you're developing a data dashboard for opioids, how do you decide what data to display on that dashboard? And fortunately, as part of the study, we developed a technical specifications document detailing about 100 measures that we tracked across the healing community study using administrative data. We're currently finalizing that document, and we'll publish it online for broad use very soon. I actually just saw a final version today, and so we will send that out. We have measures related to overdose deaths that come from death certificates. We have measures related to non-fatal overdose events that come from ED and inpatient hospital discharge data and from hospital syndromic surveillance data. We have naloxone distribution data from state public health department records, naloxone dispensing data from retail pharmacies that we purchased from IQVIA. We also have naloxone administration data from EMS records, and uptake of medications for opioid use disorder, which comes from the prescription drug monitoring programs in each state and from Medicaid claims. And this is just a sample of the standardized measures that we have across these 4 research sites. There's much more. We'll go to the next slide. So we decided that we would have 5 common metrics on all of our community dashboards. So each of the sites, you'll see they look a little different. Their dashboards each have their own look and feel, but all of them include these measures. And so the first one is the number of opioid overdose deaths. This was our primary outcome for the study. The next 3 are secondary hypotheses were formed around these, and that was the number of naloxone units distributed in a community, the number of people with opioid use disorder receiving buprenorphine, and the number of people receiving new high-risk opioid prescriptions. And then we also monitored the number of EMS runs that involved naloxone administration, and that was for monitoring adverse events and serious adverse events in the study. And so you can see the all of these, and well, H2, 3, and 4 touch on those 3 areas I mentioned, which is in our ORCA, our menu of evidence-based practices, because those were our sort of 3 main areas to focus on: naloxone, medications, and high-risk prescribing. Next slide. So as you think through your own opioid data dashboards that you'd love to create, you'll need to decide which metrics are important to monitor and visualize. And there are a lot of questions that you'll need to sort of run through. So for instance, who owns the data that you want to use? How frequently are those data updated? And what are the lags in reporting? You know, we have found that many administrative data sources have long lags. So for instance, death data, usually they're stable at about 4 to 6 months. Medicaid data, claims data require about 8 to 9 months before they are being reported. And with, you know, will that data owner, so whoever you decide, you know, you want to get data from, will they give you access to their database, or do you have to send them specifications on how to calculate the measures for your dashboard? And then ultimately, you'll need to enter into data use agreements where you're specifying acceptable use and how you'll protect the data and ensure confidentiality. Some of the questions that will go into that is whether or not you're able to show monthly or quarterly or annual data. If you can stratify metrics by race, ethnicity, or age, or sex. And all of this, you know, you want to be able to do so that we can understand more about the people that are impacted. But you'll see it's kind of challenging sometimes with administrative data, just in terms of what is available. Some of the other questions you might ask are, you know, if these data show infrequent events, you may need to suppress low counts. So for instance, you know, some of our data owners require suppression rules to protect confidentiality. For example, with Medicaid, we have to suppress counts that are between 1 and 10. I could do a whole webinar really on the steps around data acquisition, but I just wanted to lay the groundwork. So now that I've done that, I will turn it over to my colleagues at the research sites who are going to walk you through their opioid data dashboards. And we'll start off with Dr. Elwin Wu in New York.
Hi, thank you. It gives me great pleasure to introduce how New York created our dashboards and ultimately take you through some of the components and pieces to bring to life what Dr. Villani has said, as well as end with some of the lessons we've learned here in New York, which are in part informed by all of the other sites, as well as sort of learning from each other. So this, while I'm presenting New York, this really is a collaborative group effort. That is the end product is. So quickly, our dashboards, our data dashboards, our data visualizations actually lived in a larger sort of website, which we call the portal, in which case folks who are interested, or community folks interested in implementing the Communities that Heal interventions, this was sort of like a one-stop shop where they could get their electronic materials and electronic resources and communication methods to support them. But the data dashboards did live within this larger CTH portal. I'm going to switch screens that I'm sharing to a live demo site of our portal. Here we go. So here this is a sort of a demo site, or a publicly available usable demo site that gives an example or the experience of what it was like when you were in the study to interface and implement the CTH, or Community That Heal interventions. We do have within that portal was a place to access the dashboards. It typically lives in a menu up here. For the demo purposes, we've put together actually a separate link for the demo, dashboard demo. So that will be here. This is just a example of the landing page for New York when you come in and look for your data dashboards. Now, a couple of things to point out. One is that this is actually our final version. And so, as Dr. Villani discussed, as the study was rolled out from wave one, the folks who received the intervention immediately versus wave two, folks who were on the wait list initially, there were different versions of the dashboard. And so what I will share is that the initial versions would lay out the key metrics that Dr. Villani discussed and presented earlier, and presented sort of each data point as it was, and the user could hover over any particular data point to sort of get exact estimates. And in New York, we had a system for indicating suppressed data by placing it at the midpoint with a slightly shaded, a lighter shaded data point or indicator. And that would sort of indicate suppressed data. We had elements that could say, oh, display more information, that could give a little bit more of some of the nitpicky technical details on any particular measure. But for example, these would be for the opioid overdose deaths, the emergency medical services and naloxone administration. These are the data related to safety that folks could get at a glance. Now, as we unrolled some of these visualizations early on, an immediate thing came back of, oh, can you help me distill sort of all this information more like at a glance, or with only like 5 seconds of cognitive processing? So over time, where we originally just had scatter plots, we started to say, okay, well, maybe we should put in these sort of fits, if you will, or smooth out these trend lines. And that was something we put in response to some of the feedback we got from our partners and users. We also got feedback that it'd be great to actually say, well, what is a take-home message? What is something I could just say that I don't have to like go through every graph and sort of interpret? So we started to add what we called stories at various places or at the top, where you could almost copy and paste text that would give sort of a snapshot of the major news or the major sort of takeaway points that could be obtained by looking at various data. So we had these sort of stories. We also laid it out so that you could get all sorts of other measures. Wanted to point out one other major thing in that Dr. Villani talked about communication campaigns being part of the CTH intervention. And so in addition to all the administrative data, we wanted to have some sort of study process data that we could afford to the folks so that they could actually see, hey, are the communication campaigns that our own communities developed, what are the engagement rates? Who are they reaching? And so we built into our data dashboards some measures of sort of as the study unfolded, how are things going to help assist the folks implementing the CTH intervention. As far as data-driven decision-making, we're really, in New York, we're really happy and pleased and got extraordinarily positive feedback around a particular data-driven tool and a data visualization tool that is a little bit less dashboard and more of a tool that they could use to, say, potentially make some decisions around where they want to allocate resources in their particular community. And it was with a particular approach called agent-based modeling. And so it was taking some data and doing some literal mathematical modeling of how is the opioid epidemic and the overdose, the opioid overdose epidemic playing out in your individual community. So we took sort of community-based data as well as sort of, well, what is the existing naloxone availability? What would happen? Here's sort of the trend line of projected opioid overdose deaths as a function of time. This dotted line indicates the start of the CTH intervention. These were all calibrated based on local data. And this allowed users to say, okay, what if we doubled the amount of naloxone availability? What would we expect sort of the change in overdose rates based on this calibrated model with the local conditions of this sort of, in this case, a fake county? What if we could introduce sort of more and increase more medication for opioid use disorder initiation, or be able to say, hey, we can improve our retention of folks, and we can sort of estimate, this is the estimated impact on opioid overdose deaths. if you implemented these various different scenarios. So we felt this agent-based modeling, we got lots of feedback that these types of interactive tools, in addition to the visualizations of administrative data, these decision-making tools, interactive ones were quite useful, and folks really appreciated that. A couple of other things are sometimes communities develop their own sort of dashboards using proprietary data. As Dr. Villani discussed, administrative data could have lags. Who own the data? We didn't necessarily own some data. So some counties develop their own sort of data visualizations. And in this case, this was a geographic display of various resources. And so we supported this. Technically, it wasn't part of what we built, but we wanted to support that and just wanted to point it out that this relates to some of the lessons learned as we sort of deployed our dashboards. So let me quickly shift back to our lessons learned so I don't take up too much time. Some of the lessons that we've learned in New York was that there was the possibility of mis and overinterpretation of data. It could depend on, say, the data literacy. People just, appreciated they weren't sort of mathematically or graphically inclined. It's also just the nature of data itself. Since they're probabilistic, sometimes there can be a blip or an outlier, if you will, that there's just, for whatever reason, just sort of, the rates just jumped up or dropped precipitously, almost by random chance, if you will. And so that sort of presents some challenges to interpretations, as well as there's things like, the impact of COVID or policy changes that the data visualizations we felt would benefit from sort of some annotation or some context, as well as even like politics. Sometimes certain trends may or may not sort of serve politicians well, for example. And so we really wanted to be sensitive to and really serve and or redress some of the concerns that come out over mis and overinterpretation. Dr. Villani talked about sort of the timeliness data, and I gave an example of where having local data or data that could interface with already existing informatics-based tools was really important, and we learned over time. Data are quantitative typically, but having a story to tell was often very powerful, and we actually learned from Massachusetts, for example, how to interface with our coalitions to sort of say, these data are important and these are available, but let's talk about that. And that was actually really important. And finally, just as we evaluate the impact of our data dashboards, just want to point out that traditional metrics of like hits and views really subjectively or anecdotally didn't capture sort of the impact and the effect of our dashboards. And just want to point out that when it comes to evaluation, for those who are going to implement these, please do not rely on just hits and views and those types of metrics. So that's sort of an overview of the New York dashboards and some of our lessons learned. I would love to turn it over now to our Massachusetts folks and Peter Balvins.
Thank you very much, Elwin. Again, I'm Peter Balvins. I'm the Associate Director of Informatics at Boston Medical Center and representative for Massachusetts that'll be presenting today. I'll spare you from an agenda slide. There's really two things that I want to accomplish here. First, I want to share our dashboards that we developed with our coalitions, and then talk more about engagement. I think Elwin led in very well to that, to some of the engagements that we did. And as both Drs. Villani and Wu pointed out, we did have two waves to do this. So we learned from wave one, did an assessment, and so I'll be sharing, again, some lessons learned that I think will be reinforced throughout this webinar. But I'm going to share my screen and go right to the dashboard. So this is actually publicly available right now. This is the Massachusetts dashboard. This is the landing page right here. You can see 4 panels that really represent the main outcome of that we're after in the study, as well as the 3 menus: naloxone, high-risk prescriptions, and medications for opioid use disorder that was presented earlier. So this really presents a snapshot very quickly of what's gone on in the last 12 months. In the top left corner, you can see when it was last updated. This is January because the study ended in December, so it's already outdated. But you could see but that's important to know for the past 12 months. When you look here, that snapshot, you look at opioid overdose deaths, you can see in the community that is listed here, there is 25 total deaths in the past 12 months. And we included a 12-month trend here so people could get a sense of what's been going on in the last 12 months. I failed to mention this right away at the top. We have a menu of all the communities that are participating, so you can move between the different communities to see that. Back to our statistics for naloxone, this shows, again, the last 12 months, you can see that 3,354 units, a large number, were distributed. And in the past 12 months, this is increasing in the last 9 months. Looking at the other measures here, prescriptions looks like it's gone up and down a little, but fairly flat. And buprenorphine, the medication for opioid disorder, is going down at the end. You may have noticed that when I put my my cursor up here, that it hovers over. You can actually drill down, click on these, where you get more detailed information. And I should say, when we're talking about fatal opioid overdoses, we always say it's important to say that each of these lines, they represent human lives that were lost. And so we always encourage people, give that warning in case people need to leave the room or take care of themselves to be able to do that. But these data, you can see this covers about 5 years right here, 5 years of data. The community coalitions preferred bar charts. We asked them, and so that's what we made. On the x-axis across the bottom, you can see every line is a month. The y-axis is a count of the total number of fatal overdoses in that month. The numbers, you can see they're big differences between the bars. So we added this 12-month trailing average to smooth it out. So each dot here represents the average of the previous 12 months. So you can look at trends over time. Again, when you come to this page, we have drop downs where you can move between communities and other relevant statistics to the specific topic. The topic here is overdose deaths. Here you could also get EMS responses to it. So within the page, getting to relevant measures. A couple other functionalities on the right side you see here is a year-over-year change. This just shows the total number of fatal overdoses in the last year compared to the previous 12 months, the 12 months before that. So another look at it change over time. And then below that, we also have a cumulative number, which changes with the date that you select. So if I just want to look at over here and come and look at 2022 up until our most recent data, July 23, I can look at the metric there. Our page, in addition to the outcome labeled a couple times, has the description as well as the source of the data. And this disclaimer down at the bottom, Dr. Villani mentioned that there is some suppression for any number between 1 and 4. We suppressed it for confidentiality. I just want to show you one more example. We'll look at naloxone since that's a little more dynamic, the numbers that you see there. Here, the 3 metrics we have is the combined community and pharmacy naloxone. Community naloxone is generally organizations that are distributing. Pharmacy is pharmacy. And then you can see that we have these separate as well. But beware of the size of the graphs because the numbers on the sides are very different. So I've actually put this between 2019 and 2021. This is right before the start of wave 2. So this would be a look at the previous 3 years before the study started, where if you look at naloxone, you can see that 2019, there was an increase to 2020, and then it decreased in 2021. And with that, I'm going to change my share, go over to my slides, where I'm going to talk more about engagement. So wave 1, we had a very compressed timeline for the first wave. So we used our coalition meetings. We had monthly meetings where the coalitions came together And again, the purpose of the dashboards and data is to inform decision-making, in this case, selection of evidence-based practices. So a fairly comprehensive approach that I put below, we hired community data manager, dedicated staff, and they would review the dashboards independently each month. They would identify any trends, whether alarming or inspiring, anything that would start a discussion. And then they'd share these data that we labeled data bites in Massachusetts. It was an endearing term that people liked, and so we used that to share at monthly coalition meetings. With the goal to discuss and brainstorm what's going on, any reasons for the trends or opportunities. So numerous assessments after wave one, which I think Nalif will go into detail in the last presentation. But a few lessons, dedicated staff are key. It's great to have people that were really dedicated to this and pretty much this alone. As Elwin said, people prefer to have data presented to them or, in a story format. In our case, sometimes we learned that data isn't trusted. They don't know people didn't know where the state data came from. And, they wanted data from the organization, the hospital down the street. And data should be relevant to the community level. What we mean here is basically state data. At the state level, it's hard to make decisions at the community level when the level of data you have is at the state level. So getting that granularity is helpful. And the password was a barrier for some people. So quickly, some responses. We kept our staff the way it is. To give people stories, we started wave 2 with a really systematic engagement where we walk people. We did data walks with people, which I'll spend the second half of this presentation talking about that engagement strategy. As far as data is sometimes not trusted, we really took that as an opportunity to start a discussion. You could ask people what they think, how it resonates with them. Or we had a colleague who makes a lot of GIS maps for us that would call it ground truthing. Like, what's the reality on the ground? Tell me that. Let's start a conversation. And level of data at the community level, we got granular data as much as possible, but built partnerships so we could bring in more local data from health organizations and harm reduction agencies, anything just to triangulate and provide more information. And you can see from our public dashboard that we did away with the password. So to talk a little more about data walks, this engagement strategy where it's pretty much as it sounds like. We walked through data. If you look at the picture on the right, the graphics, those are 3 different pieces of data from different sources: dashboard, community profile, landscape analysis that Dr. Villani mentioned earlier. We picked ones related to the main outcomes and the menu, and broke coalitions into subgroups, whether virtual or in person, if possible, and had them react to the data with the questions at the left. First and foremost, what are the key takeaways from these data? What do you see here? What's going on? To get at that trust and the ground truthing, we'd ask if it was consistent with their understanding locally. The coalitions are the experts here. They have on-the-ground knowledge of what's going on, so we just use that as a chance to listen to them. And then move to what gaps there are in the care continuum and what opportunities exist to select EBPs to implement things in the community. And we'd always sneak in the question, what additional information would be helpful? Trying to to build a culture of data-driven decision-making and being responsive to coalitions as well. So quickly, a short case study on one station from one data walk. Weymouth, here you can see circled at the right of Massachusetts. It's an urban community in wave 2, just below Boston. This data I just showed you, this is naloxone at the left. That's the dashboard data. That is community plus pharmacy naloxone, all naloxone in the community distributed. The same graphic, you see there's an increase in 2020 and a decrease in 2021. The community data manager parsed that out in the bar graph you see to the right. And the bottom number represents community. The top number represents pharmacy. You can see that for community, there was a big increase to 2020 and then a sharp decrease in 2021. Whereas pharmacy naloxone increased slowly each year. So asking these questions, what's going on here? What do you see? Is this consistent with your reality? The discussions, there's a lot of discussion up. Like people said, maybe COVID had a role here, and they were concerned that that the numbers were dropping. They paired this with the landscape analysis, which was mentioned, which is the resources in the community. And these are resources, this is naloxone only, naloxone distribution sites that we got from web searches and talking to the coalition members about where they get naloxone. The yellow represents pharmacy, purple is the community naloxone. And you can see that within the Weymouth, the border, which the base is a trapezoid there that jumps out or budges up next to the ocean, it's all pharmacy naloxone that's in their community at that point. So even though community naloxone is greater there's people are getting it from elsewhere. So people have to travel to get it from these places. And it was a concern because at pharmacies, there's still stigma with getting naloxone. It costs money. And we wanted it to be easy for people to access. So this led to, several discussions and decisions. The gap here is a lack of community distribution and a lack of place to access the naloxone. The opportunity and what the community did, numbers 1 and 2, they hired people, a community navigator, a stipended peer to distribute the naloxone. And then they made it available at more places. They created a harm reduction center where people could drop in. Secondary, they had other organizations that they provided naloxone with to hand out, and then had nalox boxes within the community. And these are just places, things not unlike a newspaper that you'll find on the street, a box where you can get this naloxone. So that represents the Massachusetts dashboard and one of the engagement strategies we use to bring this to people. You'll notice that it wasn't strictly about the dashboard. There are people that go to the dashboard, probably a lot of people that are on this webinar right now, and then some people whose eyes just gloss over when they see data. So we tried to find ways to bring it to the whole group. But I'm going to end by saying that this brought a lot of opportunities to I guess, promote the data than the dashboards. When we use the graphics from the dashboards and the data walks, we said so. When we share these at monthly coalition meetings, we just throw it in the chat. Our community data manager had it as a part of their email signature, and we would include it in meeting notes and things like that, just to promote access and use of the data. And that ends my presentation. So with that, I'll turn it over to Dr. Daniel Harris.
Thank you, Peter. One moment. Okay, so thank you, Peter. I am Daniel Harris from the University of Kentucky. My background is computer science. I am part of the Division of Biomedical Informatics in our College of Medicine, also in our College of Pharmacy. The perspective that I'm going to be talking from today is really one, telling you and showing you what Kentucky's dashboards look like, but also from a perspective of a dashboard as a tool. And this is something that we presented at various conferences before, but the key component that I really want to highlight when we were sorting this idea out, basically wanted to minimize cost, but also maximize reusability. One of my areas of interest is reusability. Basically, we developed a dashboard library that facilitates the moving pieces of what it means to be a dashboard as web content. And we did so in an open source way. Naturally, there's plenty of commercial options available for dashboarding capable of meeting a wide variety of needs. But the parameters of the study, at least from a Kentucky perspective, in particular, the need for data privacy and fine-grained control of users and permissions, combined with the quirks of how our university licenses enterprise products, really made the commercial options less desirable. At the end of the study, we had around 500 users, and using an open source platform really gave us the nimbleness that the study needed without the administrative overhead of engaging our university for managing pieces of that. So in the beginning, when we were trying to figure out what type of technology to use, it became clear there's no universally accepted dashboarding solution that's like a no-brainer to use. So every site kind of implemented it in the way that made sense for them. For Kentucky, we kind of just created what we wish was a thing before the study actually started. We actually just made the product we wanted to exist, and we open sourced the result of that. Let me show everyone what it looks like. This is our dashboard landing page. You can pick county. I'm currently in Fayette County. There's a submenu here about working menu. I'll come back to that in a moment, but it will connect to the study materials. And then, of course, we have our map that Jen showed earlier as well. And then we just have a list of data points that people are free to browse. And they're organized kind of by theme or by how they relate to the main study hypotheses that was on the big list earlier. So naturally, we have things like overdose, either fatal or non-fatal. We have prescribing information from our PD&P. We have treatment information about medication for opioid use disorder. We have some behavioral health things that was of interest to our communities. And then we have some naloxone data as well. Before I actually show one of these, I just wanted to make a point that in terms of our lessons learned, it became clear that we were developing a tool for a very wide range of people in the audience. So in terms of community members, they pose a wide range of confidence with data, but also we're also developing this for our faculty and staff to use as well. So a really big range of people. The tool really provides some basic functionality and then some higher level functionality that maybe some people don't need, but really it's a choose your own adventure type of thing when it comes to how deep you want to use the actual dashboard itself. And just the point, I mentioned this is our public data. This is actually a superset of all the data points that were requested by communities in wave 1. Because that's a little bit overwhelming, we do organize it by ORCA menu. And I think Braden put a link in the chat to the ORCA paper. But basically, if you want to know data points that are available for safer prescribing, you can click that and it would filter that big list of measurements down. Just for the sake of this demo, though, I'll just leave the big list open. And just to have an example of something that maybe is not so obvious. So high-risk prescribing, let's click on that and walk through what our dashboard might look like. Namely, I clicked on this one mostly because what does it mean to be high-risk opioid prescribing? So there's some definitions down below, but there's also a little bit of bitty information button over here to provide more information. And it gives the basic definition. What are we actually looking at? What is the actual data in a plain English kind of way? So by high risk, it has to meet certain criteria. One of these type of prescriptions would be so-called high risk. So there's a plain English version. There's also some technical notes about how we implemented this, especially important if we're comparing to other places too as well, or published results. So the information button is there. In terms of the visualization itself, there's a lot going on here. So I'm just going to go through piece by piece. By default, we can actually control the default view as by default, we typically show yearly values. That's what these are. But you can control what time interval you're looking at. This is quarterly data. This is monthly data and so on. And you would just pan based on what you're looking at. And when it comes to time, we can have filters, or we can cut off certain years, which might be more important in the monthly or the quarterly values, but that's what that represents. Typically, we also provide counts, but also rates, which is important when we want to compare communities or to publish results for some of these known metrics already. Just hovering above one of these shows you some tooltips. So here, this is the current value is 2114, and it also shows you last year's value as well. And also just what is the desired trend, because sometimes a positive trend is desirable, sometimes a negative trend is desirable. So last year's value is higher and we deserve a negative trend, so it gets a green light basically for that. Also, if I just click on this, it brings up a breakdown of demographics. So here we see age and sex broken out for this particular measurement. Usually the demographics are associated with the yearly counts. Some of our measures are so small that the monthly counts, the demographic breakdowns for those would be too suppressed. Also on that breakdown, you could look at the particular time period, but also you can flip through the entire time period too as well, just to compare the larger time to the smaller time. Other options, we can control how information is displayed. Here we can convert that to a line graph with a toggle. We can zoom in if it's not visible by whatever your monitor looks like. Let me move zoom out of the way. Another thing that we've done is, one moment, zoom is in the way. Okay, another thing that we've done is, you can look at these measures one by one. You could also kind of minimize these and pick more things to see things side by side. So if I just pair, I don't know, say naloxone to this, I could minimize both of these guys. I can pin that guy. This is naloxone for Fayette County. And I guess I was looking at risky prescribing, and I could see these side by side. I know I did that kind of fast, but the mechanism for doing that is you can kind of sticky by clicking the pen, which means it doesn't go away whenever you look at a new visualization, and you can actually control the size of this by minimizing and maximizing. With this, you can kind of build like a custom stack of visualizations that interest you. And we were using these for presentations and whatnot too as well. Because sometimes maybe not side by side is the best way to look at something. We also have a builder by hitting the little hammer here, where you can basically mix and match measures in a single visualization. So if I do, again, Fayette County, I'm free to select any measurements from that list I was just looking at. Perhaps I'm interested in seeing how the sub-measurements of opioid overdose deaths compare to each other. So maybe I choose heroin, maybe I choose fentanyl, maybe I choose benzos, just to have something different. At that point, I have a list of measurements picked out, and I can choose how I want to visualize those. Bar graphs would just be bars side by side. A line graph would be, well, a line graph I'll show you in just a second. So this is the end result of those three data points combined, and it's color coded. So the orange on top is the fentanyl one. The green one would be the heroin one, and the blue one would be the benzo one. And then you can look at the trends over time with respect to these guys too as well. So it looks like the green line eventually becomes suppressed. There's a little gray crosshatch on the dot there, which implies it's a value between 1 and 5. All right. Another thing that I want to point out is some of our visualizations are context specific. So for example, we also have nalox box locations. So here's a map of Fayette County, and each of these icons represent where a nalox box is located. If you're not familiar with nalox box, it's basically the equivalent of a fire extinguisher on the wall for opioid overdose, for getting naloxone in the community. This 3 here just represents, it's a cluster of 3. If I zoom out a little bit, 2 is over here. So basically this location is where the nalox box is located at. Let's see. Each of these data points, each of these measurements are kind of updated on their own frequency. It ranges really from, some of these are weekly, to monthly to quarterly. It really just depends on which data set we're looking at. Timeliness, as Elwin mentioned, was a pain point for a bit of the study because some of our data sets, such as Medicaid data, has a huge lag because of the claim process. Although we have a huge interest in our from some of our communities based on behavioral health treatment from the Medicaid population. All right, I need to switch back to my slides to make a few last points. That's the gist of our dashboards. One moment. I do want to point out that we approached this from a reusability point of view. Jen mentioned community profiles in the beginning, and the profiles were really created to summarize the current state of the community when we first started engaging with the communities. In the first wave, that was really a static PDF, which Kentucky, we crafted this beautiful PDF with charts full of opioid-related data points that the communities needed to know in advance. In the second wave, our community profile was an interactive web page. We actually embedded the dashboard on that web page, and it would be updated as the data gets updated to as well. What does that look like? It looks something like this. The below here is kind of the screenshot. Our community profile in the second wave was more of a workflow process where, you know, we discuss strengths and weaknesses. Okay. Then per menu, okay, discuss strengths and weaknesses. Okay, for this particular discussion, these data points are the most salient. And there's a little, basically a slideshow of a menu that you can kind of flip through that actually brings up the data points specific to those measures that are relevant for those discussions. Let's see. We also abstracted what it means to be a dashboard. So everything that you just saw in the previous slide, there's a backend there that it's all metadata driven basically. So what is the appropriate X and Y axis labels? What is the appropriate name? What is the appropriate tooltips? All of that is driven by metadata. So the implementation of this could easily be adapted to a new setting or a new round of implementation. The code is out there on GitHub if anyone is interested. I will say there's some quick and easy data options for testing it. There is just a randomly generated data option, but if you download the JSON file that's included in the framework itself, you can swap in your own data too as well. What I was showing today is actually to start public dashboard. If you go to hcs.uky.edu, you can check it out. If you have any questions, please contact me. Thank you. I will stop sharing and hand it over to Nalif from Ohio.
Thank you, Daniel. Let me share my screen here. I want to start off by first thanking this wonderful family that I worked with for the past several years, at the national level and also at the state level. What I'm presenting today is just some of my work, right? And it's a collective effort by several individuals at the Ohio State University and the state of Ohio across so many communities. And so, without further ado, what I'm going to do today is give you a overview of the evolution of our dashboards. Storytelling here is a common theme across all the sites. So I'm going to tell you a story about how we got to our dashboards, how we worked with our dashboards over the past several years across these two waves.
Hey, Nalif, can you switch to presentation mode for us?
Thank you for
once again, hand it back to Nalif.
Am I not on presentation mode?
We were seeing presenter mode. There we go.
Oh, okay. So anyways, I wasn't talking about my slides. So back to storytelling. I'm going to tell you a story about our dashboards and how they evolved over time, and weave in some of the workflow considerations and the design considerations that we had to include as part of the process of designing the dashboards, right? So what you see here really from left to right is the beginning, right? What the dashboard looked like in early 2020, and on the right, what it looked like at the end of the study, at the end of wave 2. So a lot of changes happened, right? And one thing that was common is we did have sustainability in mind from the very beginning. We used a Tableau framework. It was because the state of Ohio was invested in using Tableau across various agencies for displaying dashboards, not just around the opioid epidemic, but other public health issues as well. I personally have done work for maternal health as well for the Department of Medicaid. So by the time I got to this dashboard, it was like my 6th or 7th dashboard. I was very cognizant about what end users wanted and preferred, right? So this is version 1. We had 4 measures, a mix of numbers, graphs. We had this component over here, sort of middle to the right, which looked like information about the stock market, right? That's kind of where we got our inspiration to summarize how we're doing for the outcome in reference to a baseline year. This was, we were very cognizant about increasing awareness around these measures to the end users. We were dealing with communities, some of which, for example, that were urban, that had competing dashboards, and others that were rural counties that were still working with papers in file binders, right? So moving to using a dashboard to look at data was a huge leap, right? So I don't want to trivialize the end user, right? Their capacity, as Elvin mentioned, and also Peter, this notion of data literacy, right? Like we were working with a very diverse set of end users. So we were sensitive to that, and we wanted to show them data from, different dimensions, right? Let's throw some numbers in there. Let's not so much text in this one, but as we got to version 2, which stuck for the longest, right? With wave 1, we had this mix of the boxes that were focused on, at least 3 of the 5 primary outcomes that we were interested in. It showed performance in relation to a baseline year. You'll also notice now that we moved from 4 measures to 12 measures, right? So there was a radial option that allowed the end user to pick a specific measure, and the graph on the right actually swapped. Now, what you didn't see here was like a version 1.9 where we had an option between line and bar graphs, and the overwhelming preference was for bar graphs, right? So implicitly, we were also doing a sub-study on what end users preferred with their visualizations. And we learned that they wanted certain types of graphs, right? They also wanted more information around the measures, right? So sort of like Kentucky had a lot more text explaining this at different levels. We, at the bottom left, you'll notice, have information about each measure, right? So you can get a brief description of the measure, its data source, the lag for getting the data, whether there was a suppression, there's also stability. The agency can go back and retrospectively change some measures if there were mistakes identified. So that lag was also noted so that, when you're discussing this data at a coalition meeting, it should kind of help you gauge your level of confidence around the measure and the decision that you're making. So I did mention that data was being processed, and so we did have a back-end workflow where data was first curated in SQL, and we had a test environment where we first deployed the data in a Tableau workbook that was not production, so that there was an internal group. And in Ohio, for the Healing Community Study, we had a setup where we had a data manager who oversaw data coordinators from all the different sites. So as part of this internal group, we gave them access to the test workbook, and they were they were given the opportunity to give us feedback on the next deployment of data to catch any errors or obvious blips, and inquire about, hey, what's going on here? Did they change the way? Did a certain agency change the way in which they were capturing a measure, right? So we should be explicit and transparent about why that happened, or to let the end user be aware of that, right? So this is also version 2, and I did switch slides, believe it or not. This is a rolled up version of the version 2 dashboard, where we actually allowed the Wave 1 communities to benchmark their county's performance with all the Wave 1 communities with the data aggregated. Like Kentucky and Massachusetts and New York, all these dashboards were embedded in a web portal that had other features like the landscape analysis. We had equally, I hope, equally beautiful landscape analyses like Kentucky. And we had an announcement page, right? So specific announcements about the study that is community specific was available on the portal, in addition to the dashboards. Okay, so as we were wrapping up Wave 1, we were beginning to actually conduct usability studies. This was across all sites. So I'm trying to take this all home here. So we are at the home stretch, and I'm trying to synthesize what all the sites have talked about today as well. And as part of our evaluation across data champions and coalition members and HCS staff, we started to understand and have this framework around what works and what doesn't work, right? And specific for Ohio, we also use the data for our end users to do some usability evaluations, right? So this is an IBM prioritization matrix, and it basically is two-dimensional. We had all these requests for things that were would be ideal with the next iteration of the dashboard before we got into Wave 2, and we were trying to, on one dimension, it went across a low and high value to the end user continuum. And the other dimension was the feasibility for our team to pull it off, considering the expectations of the study, the data stewards, and what we could do as a technical team as well, right? So we had our big bets, our no-brainers, and as part of that, some of the changes that we made moving forward into the Wave 2 updates was to have a decentralized account management system so that sites themselves can determine who has access and who doesn't have access within their community to the dashboards. We had extensive help videos on how to use the dashboards. We added tooltips. We also had this trend comparison tool that I'm about to show you, which first started out as basically a rate line, right, with the measures. You'll also notice now that we've moved from 12 measures to over 20 measures, which started overwhelming the end user, right? So as a response to that need for helping with the navigation, we actually created categories at the top that would allow you to subset the measures that were related to a specific topic at the top, so that you're not seeing all the measures at the same time. We also allowed for slicing the data by month, quarter, or year. And the definitions were also there. We did have a click for term definitions, which provided more extensive definitions for the outcomes. Now, this is the next iteration of the trend comparison. This dashboard actually allows you to select multiple measures to start having, to start making statements of association, right? Not necessarily causality, but at least have these notions of, hey, if this is what our county is doing for naloxone, how are we doing with opioid deaths over time, right? And we did allow for normalization so that the different scales didn't result in graphs with lines at the very top and the bottom. And so, interpretation is a bit challenging in that perspective, but the goal here is to promote a discussion at coalition meetings, right? So, these are some examples of positive remarks. These are from Ohio, but they, I would say, were similar comments were found in all the other sites as well. One aspect of a strong visualization, its ability to reflect what's going on in the real world, right? So the first comment is an example of that. The second one is that Medicaid data was historically very hard to get access to in Ohio. So through our study, counties were now able to see what was going on with a higher level of granularity. Another feedback was that it was nice to have these visualizations, to have conversations at coalition meetings, to look at trends. That was not something that everyone had. Since I am really into usability design, we did a cross-site usability evaluation using a validated survey. You'll see most of the responses across frequency of use, approachability, confidence is generally high. Ohio was rated for being somewhat more complex, but our scores were generally in the 70th and 80th percentile using a meta-analysis of sus scores, right? Also, since Peter mentioned this, I would be remiss to say that we didn't have, challenges with usability and the user experience that we took away as lessons learned, right? So telling a good story with the data, as you noticed, New York was using snippets in their dashboard, which is very helpful. Using the data to prompt a call to action, right? Like, what do you do with the data that I have? And aiding the end user to do that is very helpful. Passwords, I know Peter mentioned this as well. Ohio had the same challenge. We were a study, we didn't want to have cross-contamination, but it felt like we were gatekeeping, and that was something to be aware of, right? Like, how do you make, now that some of our dashboards are publicly available, this is not an issue, but when you're in a study, it's something to be mindful of. Being aware of engagement. I know Ohio did our best. It was a learning opportunity for us to use Google Analytics to track the log files of individuals using the data, to be mindful of who's using it, when are they using it, how long are the sessions. It's easier said than done. And there's an entire science around generating log files that are useful to generate insights, right? But knowing what I know now, if I could go back to day one of wave one, I would probably do it. And we did our best. And as part of our workflow, we did take the log files to steering committee meetings to share that with the steering committee at Ohio, so that everyone was aware of how the dashboard was being used. And thinking about how these dashboards are integrated in the workflow at these community organizations and at coalition meetings is also an important aspect, right? So that's something, it's nice to say now, but the science back in the day, we were still learning. Now we did do a great workshop in Massachusetts at AMIA. We have a GitHub repository, and I'm sure someone is sharing the link to that. As part of that link, we have all this output from all the sites, including Ohio, where we actually created template Tableau workbooks that anyone can use to replicate many of the dashboards that we've created. Last but not least, this is our pride and joy. We actually have a public-facing dashboard now that has been rolled out across all 88 Ohio counties. Yes, we have 88 counties in Ohio. Do pay us a visit. This has grabbed a lot of attention, and I hope is going to be used a lot as the conversation continues.